Hello, everyone. Welcome to our ICRP Madan Rehani Award 2025. It's a great pleasure for me to welcome Madan here. Um, it's also a great pleasure for me to welcome the François Paquet, who will get the first Madan Rehani Award. But before, let me very briefly introduce this kind of award. It's the first time that we have an award here. And before we start with this, I would like to introduce Madan. If you go to the website of ICRP and look at the members, you will find also some information on Madan, on his engagement with ICRP. And I was really surprised to see, Madan, how long you have been engaged and supported ICRP in various roles. This started, at least if I believe in what I found on our website, in 1997, which is almost 30 years ago, as a member of Committee 3. And this turned out to be quite a long-lasting engagement, which lasts until now. So Madan was 12 years from 97 to 2009, a member of Committee 3. He continued as a member of Committee 3, but in a way he got promoted. He became the secretary of Committee 3 from 2009, again 12 years until 2021. And then in 2021, he resigned from this position as the secretary of Committee 3, and he became a member emeritus of Committee 3. His affiliation, and he's a representative associated with his affiliation, Massachusetts General Hospital, Harvard's Medical School in the US. So this already shows how, for Madan, how important his engagement with ICRP was, and for ICRP, for us, it was also very important, of course. Now, let me come a bit closer to the award now. If you read Madan's CV, then you will find, for example, that he contributed significantly contributed as the chair of the group to 4 annals of ICRP, 4 reports of ICRP, which have been published under his leadership. And they were very successful. Those were very successful. And they were developed and published in a very timely manner. So obviously this is important. So we need publications from ICRP. This is what we are. This is our major deliverable. So we need publications, reports from ICRP, and they should be read. And obviously those Madan developed, they are, as it's written in his CV, best-selling. And of course, they should also come timely. So this was important for Madan when he worked within Committee 3. And he contributed to another 4 annals where he was a member of the task group, of the corresponding task group. And that's the reason, I guess, why Madan got the idea, and it was important for him to define an award for chairs and co-chairs of ICRP task groups. Because what task groups produce is at the core of ICRP's work. So what is the award about? Well, it should recognize exceptional contributions to radiological protection, of course. This is ICRP. And it should be awarded to the chair or co-chair of an ICRP task group who has or who have made an outstanding contribution to the timely development of an ICRP publication with a significant impact on radiological protection. And this was the idea Madan had, and we did in the main commission, we developed this a bit further together with him. And this was actually what came out, what the award is about. So eligible candidates are chairs or co-chairs of ICRP task groups. So should there anybody out there listening to our presentation today, it's a good chance. If you want to get the Madan Rehani Award, you should first become a chair or co-chair of a task group. Publication, and it's important that there was a publication in the annals of ICRP within 5 years of the date on which the award is to be conferred. Nominations may be made by any member of the ICRP main commission. And we did that for the first time for this round here. Nominations may be of a single task group chair or two co-chairs of a single task group if they are not members of the same ICRP committee. As you might know, typically a task group is set up under the umbrella under a committee. And sometimes if the topic is of interest for two committees, then we may establish a task group under two committees. This is an example. And finally, the awardee or the awardees will be selected by secret ballot of the main commission. This is how we decided, finally, of course, always in close collaboration and discussion with Madan, to identify the first winner of the first ICRP Madan Rehani Award. And now let me give the floor to Madan to explain a bit more about his reasoning, about his motivation. This was just my guess, but we have you here. So Madan, please give us your ideas why you decided to issue this such kind of award. Please, Madan.
Thank you, Werner, for your very, very kind words. I am truly humbled and honored to be in this situation and present today in the first inaugural award lecture. I know, Werner, you are very, very busy today itself, and still you found some time to be here with us. And that's kind of you, and I'm grateful. At the outset, I wish to congratulate the François Paquet for being the inaugural recipient of the award. A bit on the history, although Werner has mentioned quite a lot. I became member of ICRP Committee 3 in 1997. And at that time, the authors of the annals of ICRP were not listed on the first page as authors and only inside in the preface. So that was the situation around that time. It was only around 2009 that the first step towards recognizing the contribution of task group members was taken, and they started to be listed as authors. So thus one could see the name in the indexing site like PubMed, and it was the publication 111, through which once ICRP started to have the names of the TG member listed as the authors. So the next step which ICRP took was providing plaques to the authors of the various annals in the gala dinner in ICRP meeting. So this award, as Werner mentioned, pertains to timely development and significant impact. And the history goes back like this. I was in the first meeting of the ICRP when I became member. I was lucky to be asked to chair a task group on managing patient doses in CT. And as a newcomer, I sort of worked hard. And the next year when we met, the draft which we had prepared was considered good enough to be approved by the Committee 3. So it was in 1 year time alone that the document could be approved by the Committee 3. So subsequently, then I had the privilege of chairing another 3 more task groups, which resulted in annals of ICRP 102, 117, 129. A common theme was that we could manage to get approval of our committee in 1 year time. So that was the pattern which we maintained, and then it takes 1.5 year for publication, for the publication, and before publication, public consultation and main commission review and all that. So the timely part was very, very unique in all the 4 publications which we made. And then at that time, the criteria to look at the impact used to be the selling of the if it was among the best selling 5 top best selling. So incidentally, all the publications continued to be at least for 5 years among the top 5 selling publications of ICRP. Every year in the annual report, they used to be listed. Nowadays, there are many more parameters of impact, and the download statistics, the social media impact, and citation index, and all that. So we felt that one should go a step further from giving plaques and authorship to those who are able to have ICRP annals produced in a timely manner and have a great impact. With that, I am honored and humbled again that ICRP instituted this award, and that is how the history goes. And with that, I will thank ICRP and Werner again, and I will pass on to Werner to introduce the first recipient of this award. Thank you once again.
Thank you, Madan. Thank you very much. So I would like to share my slides again.
Yeah.
Because now I have the honor to introduce to you the first winner of the Madan Rehani Award this year, 2025. Congratulations to François Paquet, who is the first winner of this award. And he will give us a presentation on 20 years of ICRP work in internal dosimetry, an overview of challenges overcome and major successes. François, before you can start, let me just very briefly introduce you. So we know each other since many years. François is currently, he serves as the Deputy Director of Research and Expertise in the environment at the French Authority for Nuclear Safety and Radiological Protection, ASNR, in France. And I see something, this is a typo, within ICRP since 2014, not 24, 2014. Sorry for that. And please, François, if I'm wrong, correct me. He chairs the task group on internal dose coefficients. And since 2013, he's a member of Committee 2 and serves as vice chair of Committee 2. Now, François is an author, co-author of many hundreds of reviewed publications, peer-reviewed publications, including 7 ICRP publications. And this is what is all about here. We would like to honor the effort and the dedication of our awardee, François, to ICRP. And this is clearly demonstrated by the many reports he contributed to. And of course, as François is an expert in internal dosimetry, his work focuses in ICRP, his work focuses on dose coefficients, development of dose coefficients. And this is one very important deliverable of ICRP, to provide those coefficients which contribute towards harmonization in dosimetry worldwide. Those coefficients produced through the leadership of François, they are used all over the world. They are part of ICRP recommendations. And as you might know, currently ICRP is in the process to review and revise the current system and improve and modernize the system of radiological protection. And again, dosimetry, dose coefficients are in the central part of the system as recommended by ICRP. This will be important for the future, but I guess, François, you will give us many more details on your past work for ICRP, but perhaps also on the importance of your work and your task group, your committee, for the future work and the future development of the modernized system of radiological protection. François, I'm really looking forward to listen to your presentation, and once again, many congratulations. The floor is yours.
Thank you very much, Werner. Thank you very much, Madam, for these very kind words. So before to start, let me say that again. Thank you for your very nice introduction and very nice word. I am obviously very honored and very grateful to receive this prize. However, I would like to say that the work which is rewarded today is a product of a whole team. The team which is currently present in the TG Task Group 95 and the people who preceded. When I am saying that, I am thinking about the chairman of the former chairman of this task group, John Harrison, and other chairman of other task group, which also contribute to the internal dosimetry. I am also thinking about the member of the task group who are of great help for me and who are producing amazing work. And I think you will agree with me that they all deserve this award, and this is why I have shown this medal, and I will dedicate this award to each of them, to everybody. Having said that, let me go back to the subject of today. As you mentioned, Werner, it will be about internal dosimetry. I'm sure that many of you know everything about internal dosimetry, but if you agree, I would like to share some view, maybe personal view, and to share the work which has been done since the last 20 years, because we really have made many progress. And before to explain the progress made, let me say a few words about internal dosimetry. As you know, it's the discipline which is used to determine the committed effective dose. And when I'm talking about the committed effective dose, I am thinking about the dose which is given over the lifetime. And this is different from external radiation, external contamination, external radiation. When you are irradiated by external irradiation, you are irradiated for a very short period of time usually. Here in internal contamination, when you ingest or you inhale a radionuclide, it may stay for years, and by disintegration, it may expose you for years. And this is why we are talking about committed effective dose. And here we have the formula of the committed effective dose. It looks nice, it looks simple, but in reality, it is very complex formula. It is very complex to determine. When you want to determine the internal dose, what you need first to know is the intake. You need to know how many becquerels are incorporated in the body, either by inhalation, and in such a case that will depend on the radionuclide concentration in the air and the breathing rate. The more you breathe, the higher the dose. After ingestion, that will depend on the radionuclide concentration in the foodstuff and the food which is consumed. And all these data are, I would say, easily obtained just by exposure monitoring. But I will come back on that later on. The second thing you need to know, which is much more complicated to get, is the deposition in the tissue. You need to know where the radionuclide, where they go in each tissue, where they deposit. That, of course, will depend on the way of entry. That depends after inhalation, they go first in the lung, after being translocated in the organ. After ingestion, they will go first in the stomach, after being translocated in the organ. So you will have different way of deposition, different site of deposition. That will depend on the physico-chemical parameters. The particle size will influence the deposition in the lung. The chemical form, which influence the solubility of the compound, and then the translocation of the compound from the lung to the blood, or from the stomach or the small intestine to the blood. That will depend also on many biological parameters, such as the age, the sex, because you do not have the same needs. So that will depend on the morphometry. That will depend on the physiology, such as, for example, the breathing rate. The breathing rate will influence the deposition in the lung. That will depend also on many influencing factors, such as the smoking, the diet for ingestion, and so on. And what you need to know is not only the deposition in the tissue at what time, you need to know the evolution of the deposition in the tissue. So you need to know the transfer of the radionuclides from one compartment to another compartment as a function of time, almost for the whole lifetime. The second point you need to know is the number of nuclear transformation in the tissue. You know, the radionuclide will disintegrate, will provide progeny. This number of transformation will depend on the physical half-life and of the element and the progeny. Why I'm mentioning progeny here is just because you know that when we calculate dose after internal contamination, we calculate the dose which is given by the element itself, but also we include the dose which is given by the progeny, which is formed by the parent. And when you have something, progeny, many different progeny, we have to take into account every disintegration of every element in the long list of the progeny. So this is something we need to know. When you know that, you need to know what is the emitted energy from the disintegration of the radionuclides. This emitted energy will depend on the nuclear emission for a given radionuclide and for the progeny. That will depend on the yield of the energy for each type of radiation. You know, for example, if you have one radionuclide such as americium will provide gamma emission, but also alpha emission. And you need to know the energy for every type of radiation. Once you have done that, you are very close to be able to determine the absorbed dose in the tissue, which is the first term here in my formula. You know, the absorbed dose is nothing else than the energy divided by the mass. So the energy, we got the energy in the previous step. Now you need to know the masses of the organ. Either the organ, when the cell at risk are homogeneously distributed in the organ, or when they are not homogeneously distributed, we prefer to calculate the dose directly to the cell at risk. And so you need to know where they are in every tissue, and the geometry between the source and the target. What I am saying that is that, for example, when you are dealing with short-range emissions, such as the alpha emission or beta emission, which have a very short range in the tissue, you need to know very precisely the distance between the source and the target to try to calculate the dose which is given to the target. And of course, that varies according to the mass, that varies according to the individuals, and that varies according to the age. So you need to know everything. Then, once you have the absorbed dose, you want it to multiply the absorbed dose by a kind of coefficient, which is about the relative biological effectiveness of the different type of radiation, which, by the way, also depend on the biological endpoint. We have different effectiveness depending on what you are looking at. Then, to obtain finally the committed effective dose, we want to multiply all this by a new weighting factor, which again depend on the relative risk for each organ and tissue. Again, that will depend again on the age, of the sex, and many other factors. So at the end, if you put everything together, that can be a very nightmare to calculate a dose because you need to know many things that you usually do not know. This is why, and this is where ICRP comes to help you. ICRP propose many tools and propose many things. The first thing that ICRP propose is just to reduce, I would say, the diversity of situation. I told you that the people are all different from each other. So ICRP proposed to calculate those not to every individuals, but to calculate those to what they call reference individuals. This is why ICRP defined a reference male, a reference female, with reference age, 6 reference age, all with fixed anatomy and physiology. That will really simplify the system. The second source of simplification is to define reference situation of exposure. This is where ICRP has defined reference worker, who are sex average, and reference member of the public of different age. And all these member of public and worker do have, I would say, a fixed anatomy and fixed physiology. ICRP also propose for different situations of exposure what they call default parameter for different exposure conditions, such as particle size, chemical form, and so on. And please note that the people who want to calculate those may have the opportunity to change the particle size and the chemical form in the model if they need to. They cannot change the reference male and female, but they can change the default parameters. Then ICRP proposed tools and models for each of these calculation steps. I will come back on that later on. And to avoid any complicated calculation, ICRP also proposed to simplify again the system, and they proposed dose coefficient, as they were mentioned by Werner, dose coefficient for this reference situation. So how it looks like, this coefficient, I would say a kind of magic number, which allow you to go directly from the intake given in Becquerel to the committed effective dose given in Sievert. This committed effective dose takes into account every information which is in the right side of my diagram, and every information is just summarized in one data. So this is why they are so important, and they are in fact actually very easy to use. Just to calculate the dose, it takes you 1 or 2 seconds compared to maybe weeks or months if you try to do each step of the calculation by yourself. When you do not know the intake, that may happen, you may use bioassay data, I mean the radioactivity which is in the urine or in the feces or in the lung, and by using bioassay functions that are given again by ICRP, that will allow you to calculate the committed effective dose just by knowing the radioactivity in the bioassay. So this is where ICRP really helps you. And this is now, I would like to show you what were the progresses made over the last 20 years at different steps. In fact, the task group has worked many task group has worked very hard just to improve the quality of the information, the quality of the model, the quality of the tool, and to try to be more and more and more precise for every of these steps. I will not show you everything because it will last one day, but just let me show you some example of the major advance and major progresses which has been made. First point, at the early beginning, I told you that you need to know the intake. In fact, ICRP has provided new guidance and monitoring program and bioassay interpretation a few years ago. ICRP explained you in this publication how to use the bioassay to calculate and to know the intake. In the second step of the procedure, which is probably one of the most complicated, the deposition in the tissue, you remember I told you about every parameter which are so important. In the deposition in the tissue, in fact, they are given by what we call biokinetic model. Biokinetic model will help you to know, to define and to predict the behavior of the element after ingestion or after inhalation. I will not go too much into detail, but I will need more time, but just to show you this diagram. This is about the human alimentary tract model, the former model on your left, which was made of 6 compartments, with 1 transfer here, and the new model, which is currently in use, which was published a few years ago, with about 20 compartments. And in these 20 compartments, you can see the sophistication of the model. We have everything there. The physiology of the body is in this model. And after ingestion of radionuclides, we recognize that you can have deposition on the teeth, that you can have deposition in the different wall of the small intestine and the colon. We have also then transfer to the blood, and we have a kind of recycling here. That means that we model and we give the data to recycle the element, and this is taken into account in the model. The same is for the human respiratory tract model. And I would like just to show you some more example here, because this model is a perfect example of how this model are sophisticated. The human respiratory tract model describes the time-dependent behavior of gases and particles. So they describe the deposition of the particle in the lung. They describe the transport of the after deposition in the lung. They describe the absorption from the lung to the blood. And they do that according to the chemical form. They take into account the evolution of the chemical form after inhalation, because they evolved in the lung. They take into account, they give you everything you need about for the deposition according to the size of the particle, according to the hygroscopic property of the particle. They can grow in the mouth, and so that will change the deposition. They give you this information according to many anatomical parameters, which are sex and age dependent. They also give you all this according to the age, the sex, the ethnic group, the activity, depending on which will play on the ventilation rate. They also take into account the smoking, the disease, the pharmaceuticals, the air pollutant, etc. So at the end, what I would like to say here is that I told you that we provide those coefficients for reference situation and reference male and reference female. But with this model, in fact, you have the opportunity to change to live from the reference individual and to change according to what you need. So this is really important. And I'm very proud to say you that this model has been set up for radiological protection, but actually it is used also for chemicals by other agencies, which use it because it is really sophisticated and really precise. So let me give you an example, because it's really funny to see the precision of this model. And let me talk about the deposition of particle for a reference worker. In the model, you can find this diagram. This diagram shows you the deposition of the particle according to the size in the different compartments of the lung. You have the extrathoracic airway, and in the thoracic, you have the bronchial, bronchiolar, alveolar, interstitial here. Here, this diagram tells you that if you take the particle of 5 micrometers, which correspond to the default size for the worker, it tells you that the particle will deposit mainly in the extrathoracic compartment and for a small part in the alveolar region. That's fine. If you take 1 micrometers, which is the default particle size for the member of the public, it tells you that the repartition will be different. But let's have a look on the very small particle, 10 nanometers and 1 nanometers. You have here a very strong difference between the two compartments. What this diagram tells you is that for 10 nanometers, the particle will deposit mainly in the alveolar region, and for the 1 nanometers, they will deposit predominantly in the bronchial and bronchiolar. And you will ask me, what is the difference? In fact, the difference is enormous. The difference is enormous because the mass of this tissue is not the same. You have a factor 1,000 between the mass of the alveolar and the bronchiolar region. And if you remember well, I told you that the absorbed dose is the energy divided by the mass. So that means that for one particle, depending on the size, you may have a difference of 1,000 in terms of dose in the lung. And this is, by the way, this is why for the radon, for example, you know, so for the radon, the progeny of the radon, we have the unattached fraction, which is supposed to be 1 nanometer, the size of 1 nanometer. And this is why this part of the unattached fraction is so important for the dosimetry, just because it will bind to a small region, and so it will deliver a very high dose. So you can see the precision here and the consequence in terms of dose. Another kind of example of progress on the systemic model after the element is solubilized in the intestine or in the lung, it goes to the blood, and then it is distributed in different parts of the body. Here, just one example. We have one model for every element. So this is just the example of the iodine. I put you the example of iodine because everybody says that, well, iodine is easy because it goes to the thyroid. That's true. Iodine goes to the thyroid, but in fact, it can go to two different compartments in the thyroid. It can go also in different compartments than the thyroid. So in fact, again, this is an example of the complexity of the model and the precision of the new model. Still in the deposition in the tissue, I told you that we need to know the behavior of the progeny, and we have made also a very nice progress these last years just by taking into account the independent kinetic. By the past, we use, I would say, a shared biokinetic because it was too complicated to define the independent kinetic. And in the new model, we use this independent kinetic. That means that we assume that an element will behave differently from the parent. And that oblige us to set up new model because depending on where the progeny is born. For example, for the radon is a gas which can go to the fat, and we had to define new model with, for the bismuth, for example, or the polonium, where the element is born in the fat. So we had to set up many different new models. For the transformation in the tissue and the emitted energy, ICRP has completely revised the nuclear decay data, and they provide a kind of software, which is, by the way, free to download from the ICRP website. I really encourage you to go there. It's really easy to use. When you click on one element, you have everything you need in terms of yield, of production, in terms of energy, for different ray, for different isotope, and this is a really important source of information. Now, the next step was about the absorbed dose in the tissue. Again, absorbed dose is the energy divided by the mass. So what do we need? We need the mass, and the mass has been completely revised with this new reference, male and female, which was produced in 2002. We have produced a document which provides a number of information about the anatomy, the physiology of different age, and so including age and specific data. This is amazing, the amount of information you can find them, and that will provide every masses you need to make the calculation. By providing the mass, we also provide the location of the target for the cancer induction. In some cases, we assume that the target for cancer induction are homogeneously distributed in the tissue. This is, for example, the case for the liver, but in other tissue, for the skeleton, for the bladder, for the human alimentary tract, human respiratory tract, we have defined specific target cell for cancer induction. And just let me show you one example and the difference it makes in terms of dosimetry. Let me show you so that example, the case of the bronchial wall in the human respiratory tract. We have modeled the location of a specific cell in this diagram. We assume that this is the lumen here of the human respiratory tract. This is the blood. And we assume that the target cell for the cancer induction are the secretory cells and the basal cells. And let's see what happens now when a radionuclide goes in the body. For example, the case of the radon progeny, one of the progeny is polonium-214 with the alpha energy of 7.7 MeV. When this particle binds to the mucus layer and it disintegrates, it will produce radiation which will irradiate the secretory cell and the basal cell. But one of the progeny is polonium-218 with a lower energy. And so if the polonium-18 deposit at the same location, Because of the shorter range of the radiation, it will irradiate only the secretory cell and not the basal cell. So at the end, you have no dose here. You have a dose here, but not here. And this is taken into account in the new model. Other example, in the HAT model, you have here an autoradiography taken from guinea pigs. So we are not guinea pigs, but we have the same kind of image for the human. You can here see the deposition of plutonium in this villi. And this is interesting to know because the target cell for the cancer induction are supposed to be here. So that means that after alpha disintegration, you have no dose according to the model. And that makes a big change when you calculate the dose so you have dose here, but not to the target cell. So this is important to know. I told you about the masses. The masses are represented into phantom, which are used to calculate the dose. Just show you this diagram. By the past, we had this mathematical phantom, which are, by the way, still in use for some application. These mathematical phantom were very nice and really helpful, but the size here and the shape of the organ were represented by mathematical equation. Now we have made progress. Some years ago, we used voxel phantom, which were obtained by tomography image, and which with a greater level of details. Then we have used a kind of mixed phantom, and now we have a new generation of phantom, which were just published by ICRP, the mesh phantom, which a higher degree of realism. Here in this new phantom, we can represent the target cell, which was not possible here. We can represent the target cell, target layer, and so on. So we again increase the level of sophistication and our ability to calculate the dose. If you are not convinced by my first diagram, show this, have a look to this one. The human alimentary tract by the former model and the human alimentary tract by the new model. It's not only pretty, it's just more precise when you want to calculate the dose. And so where we are now, we have the whole family of the phantom. We have the pediatric phantom and the adult phantom. And the next step is now to produce a pregnant female phantom at different stage of gestation. And by the way, you may provide comment in this ICRP, which is currently under consultation. And of course, we have also this this embryo and fetus at different stage. Almost last stage, when you want to calculate the absorbed fraction, the absorbed dose, you need to calculate the specific absorbed fraction. The specific absorbed fraction is actually the fraction of energy which is emitted by a source, which is absorbed by a unit mass of the target. So we need to know that just to calculate the dose. And just to show you what we have done, in the biokinetic model, we have about 80 source regions. This is where the radionuclide goes. We have defined 43 target regions, which are sensitive to radiation, 6 age, 2 sex, 4 radiation type with 28 or 24 different energy. And at the end, if you multiply every number, that end up with 3 million of data points. And that I would like to highlight that to do that, we had to calculate 3 million of data. These 3 million of data had to be QA'd. So we had to do that many times just to provide the tools that we need to calculate the dose. So just a few examples to show you this SAF are produced in ICRP publication under this time of graph and table and software. And this is just to show you that SAF can vary according to the sex and to the age. So we had also new weighting factor. And what also new progress which has been made is with this concept of dose per content. Very rapidly, by the past, when we had the bioassay, we were obliged to go to the intake and then to calculate the effective dose. It was two steps, so two sources of error. And what we wanted to do is to reduce the risk of making a mistake And so we now provide the dose per content, which allow you to go directly from the bioassay to the effective dose just by using one data. So what are the outcomes of this progress? I would say that everything that I have said, everything that I have presented is now embedded in the new set of dose coefficients, the new series, which has the occupational intake radionuclide series for occupational intake of radionuclides for the worker. We have provided 5 publications from 2015 to 2022. In this publication, we provide a review of data on inhalation, ingestion, systemic behavior. We provide the biokinetic model and data. We provide the monitoring techniques and detection limit. We provide the coefficient and bioassay function for about 1,200 isotopes for different chemical form, for different particle size, and we also provide data for exposure by submersion for the noble gas. And all this is also given in the application data viewer. We just have a screenshot here, which show you that instead of going to the publication, you can have everything in an electronic format, so which is more easy to use. We are producing currently the same thing for the member of the public. We have 2 parts which are already approved for publication, one which will be posted on the ICRP website pretty soon, and 2 other parts on the embryo, fetus, and nursing infant, which will be produced in the coming years. And so we are almost finished, and you can say, okay, so what's next? In fact, we have still many things to do. And we have still many things to do because despite of the progress we made, we still have those coefficients which are very precise, but which will not allow you to estimate what I would say the real dose, the real individual dose, and therefore the individual risk. And why are we there? It's just because here in my formula, you remember my formula, in fact, we have 2 components. We have one component here, which is, I would say, the physical component, which is physics, which is the absorbed dose, energy divided by the mass. And now we have made so many progress that I really think that we are almost able to calculate the individual absorbed dose. We have now a library of many phantom, and if we continue to work, we will be almost ready in a few years to calculate the almost individual absorbed dose. This is achievable. The problem is the second part of the formula, which is about the risk. The risk here with the two weighting factors, which are derived from epidemiological studies, and because of the quality of the data we have, and because we are dealing with statistics, we were obliged until now to average over sex and over age the weighting factor. So if we average here, we cannot have at the end individual risk and individual effective dose. And this is where we have much to do. But ICRP is still working on this subject. So just to finish, I'm sorry if I was a little bit long. So as a take-home message, I would say internal dosimetry, I think you will agree with me, it's complex. It's a complex discipline, but at least doses can be easily calculated using dose coefficients, which are provided by ICRP. We now have very sophisticated models and new dose coefficients, which have just been produced and who are currently being produced for the member of the public. We have a very incredible level of detail in the model, but however, despite this level of detail, the dose coefficient still remain for radiological protection only. And when I'm thinking about radiological protection, I am thinking about justification, optimization, and limitation. They are not yet for individual risk assessment, but ICRP is working on the project, is working on the question, and they have set up a task group on individualization and stratification. And who knows, maybe in the next decade, we will approach what is asked by almost everybody. We will approach this concept of individual dose, at least for the patient, because we agree that for the patient, it is more important according to their state of health and the dose they receive. So that's it. Thank you very much. I'm finished and I'm ready for your question if you have some.
Thank you, Francois, for that. So yeah, we do have a few questions, and the first one, Francois, is if you don't mind, could you suggest a software for internal dosimetry calculation?
Well, there are many, and I won't. I won't recommend any. There are many, and I think you can test the one which are available, and you can understand that I cannot recommend any.
Sure. Well, maybe is there a few places where somebody could go to find one of these, or if they just search?
Yes, I think it's easy to Google, and there are many companies who are providing, and many agencies who are providing some software, and I'm sure I know that some of them are listening to us now, and they can provide, but yeah, I will not recommend any of them just for a deontological reason.
All right. So the next one we have here, can you elaborate on the ethnic group influence on the HRTM?
Yes, in fact, we have by the data which are available, we realize that, for example, the different ethnic group do have different characteristic and physiological characteristic. For example, I can't remember the name. The way you breathe and the volume of the lung and the vital capacity. This was the word I was searching. The vital capacity, for example, is different from one ethnic to another ethnic. And this is important when you want to calculate the deposition and the inhalation and the deposition in the tissue. So that has to be taken into account. In the model we use, we define the reference parameter, reference person is a Caucasian person. But again, if needed, that can be changed. But what I would like to emphasize is that the ICRP philosophy is in any case just to start when you want to make calculation, just to start using the default parameter and the reference parameter, and only to change the default parameter if you end up with a dose which is close to the dose limit. If the dose you are dealing with are about nanosievert or microsievert, that will not make so many difference. So we really recommend to use the default parameter unless you approach the dose limit, or if you need to have a specific risk assessment for a specific situation.
Perfect. Thank you. Another one here. So thank you for the interesting presentation and your work for the system of RP. Could you please remind us what the reason for ICRP to increase the dose CF, maybe that's coefficient, I'm not sure, for radon and the implications of the increased occupationally exposed workers?
Wow, this is a question that we are facing for years, but it's a very good question. In fact, radon is very special case for different reasons. The first of the reason is because radon is a gas, and in fact, the dose, most of the dose which comes in reality from the radon progeny, and so which are solid progeny and which have different behavior from the gas. So this is one of the reasons for which it is different. And the second reason is that for the radon, and especially for the radon, we do have very, very good epidemiological data for the minor from the residential studies. And because of this quality of the epidemiological data, for many years, in fact, the dose coefficient were not calculating using the dosimetric system that I just showed you. The dose coefficient were calculated using epidemiological data, so we're using nominal risk from the lung cancer in the minor which was divided by the risk of having a cancer from the Hiroshima-Nagasaki exposure. So we did have this conversion coefficient, dose conversion coefficient. And what is important to notice is that in I think it was in 2010, the ICRP has revised the nominal risk coefficient, and they end up with by doubling the risk. In fact, they just took into account new data from epidemiological study, and they conclude that the risk should be twice as it was by the past. And if the risk is twice, at the end, the risk coefficient should be twice. At that time, ICRP decided to also calculate those coefficients for the radon using the dosimetric system, which was not made by the past before because of the complexity of the situation. This is what we did, which was published in 2017 in OIR Part 3. And what I would like to mention is that we did obtain, using the dosimetric system, we did obtain exactly the same coefficient than the one which were obtained using epidemiological data. And this is, I would say, one kind of demonstration that our dosimetric system is very precise and really and that the coefficient were the right one. And this is why we end up at the end by doubling of the dose coefficient. And for some specific situation, we did also multiply by factor 4, but this was only for specific situation, such as a touristic cave, because of the characteristic of the progeny of the aerosol.
Wonderful, thank you. And next up is a question about AI. You know, it's a popular topic within ICRP right now, and we're doing lots of work on it. But have you thought to use AI for individual risk assessment?
Not yet. This is a good point. This is funny because I've got the question almost every time. So yes, we need to think about it. We need to think about it. For the derivation of the dose coefficient, we did not use IA. We use, I would say, use human intelligence only. But this is something we need to integrate and to think about it for the next work. Definitely.
Thank you. Yeah, so we have like 3 or 4 more. Maybe we'll just go a few minutes over time here, just so we can get to all the ones. So everything that's submitted now, we will try to get to. But so the next question is, can you please tell us about the changes in target regions and skeleton and dosimetry?
Yes, in fact, well, it's too bad because I've got a scheme that I did not present it here. In fact, we just provide more precision about the location of the target cell in the skeleton. We have defined different regions in the skeleton. With the different location also of the bone marrow, 2 types of bone marrow, and so by just provided a more precise localization of the cells, that allow us to better define the quantity of energy which is effectively delivered in the bone. What is important in dosimetry is that, of course, when you have a radioactive element, when it disintegrates, it will irradiate everything around. But what we need to know exactly is we don't care about what we call the wasted dose. The wasted dose is the dose which is delivered to a tissue or cell which are not sensitive to radiation. And what we need to know is the dose which are received by the cells sensitive to radiation. And just by better defining the localization of this sensitive cell, we just increase the precision of the dose to the bone, and therefore the risk to the bone, and at the end, the accuracy of the effective dose itself.
Perfect. Thank you. Next, how can these last studies affect the regulation or regulations, I guess?
Well, that depends on the country. What I can say is that in Europe, it will be easier for me to talk about Europe. In Europe, we have the European Commission, which now recommend to use the new dose coefficient provided by ICRP, at least the one provided for the occupational intake, because the one for public intake are not yet produced. And so so they will be gradually, this will be gradually taken into account in the different country. It has already been taken into account in France. For the radon is a specific case, so we may have still discussion. We have many discussion actually about the radon for many reasons. So it is not necessarily yet adopted in every country. But what we see, if you look back in the past, what you see is that usually the ICRP dose coefficient are at the end included in the national recommendation. So for now, we have the OIR series has just been produced, so it is not yet completed, but I'm really confident that it will be in the next year. And in any case, if it is not, we are here to discuss with people and to explain why we make this change and why we think that the new model are the best one.
Perfect. Thank you. So I've got about 3 or 4 more here. The next one, when we have limited resources for dose individualization, which do you think we should prioritize first between the biokinetic model or the anatomical model?
Well, I'm not sure I can see. I will say both. I'm sorry. No, well, we have, I think, I'm not specialist of the phantom, and of course my colleagues who are there maybe will not agree with me, but I think now for the phantom we have now so sophisticated phantom so that can be used right now, and I can't see how they can be more sophisticated than they are now. For the biokinetic model, things are more complicated because the biokinetic model relies on the data we have. And some biokinetic models were made from human data, which is fine. Some other biokinetic models which were made from animal data, which is less fine. And some other biokinetic models were just extrapolated, I would say, from other models from the same chemical family, just because we do not have data. We have about 108 elements in the periodic table of the element. And so some elements are very well documented and some others are not. And when this model were produced many years ago, we at that time we had some laboratory producing some data on the biokinetic, and we have less and less of this laboratory. So we have less and less new data, new biokinetic data. And I will say that can be a source of progress, just to try to get new data to better refine the knowledge on the deposition and the transfer of the element. But again, this is just my personal opinion. So in any case, the best will be to work on every step just to again refine the system.
Perfect. Thank you. So we've got 3 more that came in before 9 a.m. So we'll try to get to those 3. So if individualized doses are available, the quantitative analysis of low dose cancer risk remains unclear. Therefore, what is the practical meaning of individualized internal dose assessment?
Well, this is a good point. In fact, when I am, again, many people may have different view. My just personal opinion is that having individual dose when you are dealing with very small dose is not really is nonsense. I mean, I will not see a great interest of trying to individually have individual dose for a very low level of dose. What I am thinking about the interest could be really in the medical procedure for patient. Patient first, there are usually patients that are not in good health. This is first point. The second point is that they may have dysfunctioning some organ, or even they can have some organ which are missing. And so we cannot calculate effective dose for these people. And the third point is that this patient may receive a very high dose, high level of radionuclides for medical procedure and so on. So I really think an interest here to try to individualize the dose, just to let the medical doctor, just to let them know better what they are doing, and just to I would say to change and to modify the procedure according to the people. For example, again, when you cannot have the same procedure for somebody weighing 50 kilograms and somebody weighing 100 kilograms. And this is where we need to have a kind of individualizing procedure and so to have individual dose. Sorry, I'm tiring. But you understood what I am saying.
Sure, yeah, perfect. And so we've got two left that we're going to do. So please explain, is there any effective method to decontamination of internal contamination? And please explain the acute and chronic contamination exactly in terms of time.
Well, for the decontamination, yeah, we have drugs which help to reduce the level of contamination. The most famous of this drug is the DTPA. The DTPA has been used for years, for decades, just to remove some elements. The DTPA is very efficient for many elements. Is not efficient for uranium. For uranium, we should use another, which is a bicarbonate salt. Some years ago, 20 years ago, we had many laboratories working on trying to define new molecule. Some of this molecule were the first molecule which were found where we had the theory of the LiOPO and so on. Unfortunately, the LiOPO is a little bit toxic, at least a little bit more toxic than DTPA, so it is not really used. I know that some people are still working, or I think I know that some people are still working in this field, especially in Berkeley. And so, but at the end, the good news is that we have these drugs which help to reduce the level of contamination. What I did not mention is that the dose coefficient that we are producing cannot be used. Well, you cannot calculate dose with this dose coefficient if you are having patient or workers treated by DTPA, because the DTPA will enhance the excretion of the radionuclide, and this is not modeled in the ICRP model. So if you do that, we need to have specific model using DTPA. So this is for the first question. The second question about acute and chronic. Well, acute again, we do not have a very strong border between the two. For me, acute, when I mentioned acute and chronic at the early beginning of my talk, I was talking about having a flash exposure or very short-term exposure. A chronic exposure is something where you are exposed every day. But in between, you can have, can't remember the exact name, it's not mid-chronic, it's a subchronic exposure, so you can have everything you need. What is important at the end is just to remind that anyway, the ICRP coefficient are given for acute exposure. If you are dealing with chronic exposure, you just add the exposure at the end, because the hypothesis is that the exposure are additive. This is a very strong hypothesis, but this is on the basement of the system.
No, that's great. And the last questions that are here kind of deal a bit with like questions around like radiopharmaceuticals, which I think you just kind of addressed in the last question here. So I think that we're good. Thanks for everybody for sticking around a few extra minutes for the Q&A. So Madan's kind of hopping back on here. Madan, if you wanted to provide some closing thoughts, and then I can end the webinar after that.
Thank you, Kelsey. Thank you, Francois. Thank you, all the participants in the session. It has been a really nice session, and the medal and certificate associated with the award will be presented in Abu Dhabi meeting of the ICRP. And with that, thank you from my side.
Yes, thank you, Madan, and congrats once again to Francois. As Madan said, the award and this presentation. Oh, Werner's back on. Werner, if you wanted to add any final thoughts.
Yeah, I just also wanted to congratulate Francois again for getting the award, but also for his brilliant presentation. And I would also like to thank Madan for his brilliant idea to initiate this award. And it will not be the last award as far as I understand. I hope there will be another one in the future, I'm pretty sure. So thank you, Madan, thank you, Francois, and I'm looking forward to Abu Dhabi to be present when the medal will be handed over to you, François.
Thank you.
Thank you.
Thank you very much.
Yes, and so again, that's the end of our webinar today. Thank you, Werner, Francois, and Madan for today, and thank you to everybody for attending, and thank you to those who supported this event with a paid ticket. It allows us to kind of keep doing these online and digital events and providing them to free of cost around the world. Whenever you can, always keep track of ICRP.org. You can find all of our events that are coming up, either online and in person, with the next one being our Task Group 99, which is the end of June. So keep your eyes peeled for that. Again, thank you to everyone today, and have a good day.
Thank you.
Bye, everyone.
Bye-bye.